This conference will now be recorded.
Okay.
Yes, ma'am.
So, okay, thank you so much. So I'm welcoming you all to the talk session as the recording just started. So I'm starting again. So yeah. Can you see the second slide? Yeah. Okay. So I'm pretty much sure that you girls are very much familiar to the TOG. And this is from 2021 and TOG issue 23, volume 3. And the topic is non-epithelial ovarian cancers. You guys are master in oncology, I'm pretty sure, and you have already studied a lot about ovarian cancer. And there are so many talks related to ovarian cancer, and nowadays RCOG is very much fond of carcinoma. And in every talk, there may be a topic related to either ovarian cancer or related to endometrial cancer, or there may be cervical cancer related topic. So we can expect any question from any kind of cancers, and you should be updated about the talk issues as because these are the recent talks. Okay, so can we start now? Okay, if anyone has any question, kindly raise your, yeah. So if anyone has any question, please raise your hand button. I will advise you to write down the questions and ask in the question answer session. This is not a very big class, only about for 1 hour. We have a question answer session at the end, and also I have a question from the RCOG website related to this talk. So I hope you will enjoy the slides. Okay. It's being a bit slow. The slide is, yeah. Kindly let me know, is the slide is moving? Hello. No, okay. Yes. Probably this is the network issue. That's why the slide is moving slow. Are you guys saying that in the UK, ovarian cancer is the 6th commonest cancer? Okay, so in the UK, ovarian cancer is the 6th commonest cancer in women, and it is responsible for over 44,000 deaths annually. And non-epithelial ovarian cancers are rare, and it accounts of about 10%. So in this talk, we can see that they have divided the non-epithelial ovarian cancers into 3 classes. That is the malignant ovarian germ cell tumors, sex cord-stromal tumors, and ovarian sarcoma. I'm sure that you all know about this, but in this talk, they have specifically described about the classification and also the stage-wise management. So we are going to discuss about that. I'm not sure why the slide is moving too slow. Sorry, guys. Yeah. So, yeah, can you see now? Yeah. Okay. So they have described some anatomy of
Yes,
the
ma'am.
ovary.
Clear.
Okay, thank you. So they have described some anatomy of the ovary, and we all know about the cortex and the medulla, and the cortex is lined by the cuboidal epithelium, and the inner portion contains the neurovascular structures. There is the hyla, and also the lymphovascular structures are in the medulla. So the outer cell line, that is the cuboidal epithelium, gives rise to the epithelial cancer of the ovary, and the hello. Yeah, I will be requesting you to mute your microphone, please. There are some background noises. Okay, so the medulla of the ovary is formed from the embryonic mesenchyme, and it contains the lymphovascular structure. And most of the non-epithelial ovarian tumors arise from these specific cells like germ cells, the granulosa cells, theca cells, stromal fibroblasts, and steroid cells. Yeah. So starting with the ovarian germ cell tumors, it often presented more acutely and at an early age. And this is a rapidly enlarging pelvic mass, which may be acutely severe presentation with lower abdominal pain, and there may be tumor rupture, hemorrhage, or torsion, and maybe there is dysuria, urinary frequency, and menstrual irregularities are common, and they may present with the symptoms of a tumor-related HCG production, such as positive pregnancy test, and also hyperthyroidism is also a common presentation with the germ cell tumors. Okay, so these are the few points which have mentioned in the talk, that the oocytes are totipotent cells that may can become any tissue within the embryo, so that the germ cell tumors can grow from any three type of cell, that is the trophoblast, yolk sac, or embryo. I'm extremely sorry. I don't know why the slide is being so late to move. Yeah, so this is the germ cell tumor classification according to the World Health Organization 2014 classification. This is the germ cell tumor can be teratoma, and we all know that can be immature and mature teratoma. There is the embryonal carcinoma, and also dysgerminoma, yolk sac tumor are there. You don't need to remember all the classification. I have also so many tables in this talk in further slides. You don't need to memorize all of the name of the tumors, but remember that the germ cell tumor, in largely they have described about teratoma, and also the embryonal carcinoma, and this dysgerminoma, yolk sac tumor is also there. So these are the name of the tumor you should remember. Okay, so this classification of germ cell tumor, we all know and we have read in the strategy that the germ cell tumor can be differentiated and undifferentiated. Can you see my slide? I have moved, but I think you are not seeing the new slide.
We can see, ma'am.
Okay, so it can be differentiated and undifferentiated, and the only undifferentiated germ cell tumor is this germinoma that can happen in 45% cases. And this chart is from the strategy, so you have to remember it with all the percentages. And the differentiated germ cell tumors can arise from various type of tissues, as I said, the embryonal carcinoma, the teratoma, yolk sac tumor, and choriocarcinoma. And choriocarcinoma is the least one, as because in other than pregnancy, it's actually very, very less common. That is less than 1%. Now, in contrast to the epithelial cancer, where the bilateral ovarian involvement is not unusual, but unilaterality is the typical for ovarian germ cell tumors. Like in 10 to 20% of these germinoma are bilateral. So mostly it can occur as a unilateral tumor, but in case of this germinoma, about 10 to 20% of this germinoma may be bilateral. Kindly remember this percentage as because this is an uncommon finding, that's why it can come as an SBA. So on examination, we can find distended abdomen, pelvic mass, ascites can be there, and there are a few features of advanced disease like pleural effusions, palpable lymph nodes, and hepatomegaly as well. So now the most important chart of this talk, probably I have taken this chart from the previous talk related to ovarian cancer. This is not in the this talk, but you have to remember all the tumor markers related to the non-epithelial ovarian cancers. So firstly, for germ cell tumors, they have written it here in the table in a manner of the tumor markers first and then the name of the ovarian neoplasm. But I have written it down as according to the name of the tumor so that you can remember. Like in this germinoma, there can be raised LDH, HCG, and also in embryonal carcinoma, it can be alpha fetoprotein, LDH, and dihydroepiandrosterone. And in choriocarcinoma, HCG and LDH, yolk sac tumor, LDH, and alpha fetoprotein. I will request all of you to remember these tumor markers because there are so many questions in the SBA, also in AMQ can come related to this tumor marker. Okay. So the next slide is showing us that in the preoperative period, there are some tests we must have to do. And we all know from the Green Top guideline that in premenopausal women, if there is an ovarian mass, we have to go through some process. And in postoperative women, postmenopausal women, we have to go for CA125 and then TVS, etc. So along with that, regarding the age or the menopausal status, we have to do some tests also like TVS, the CT scan of thorax, abdomen and pelvis, chest X-ray and blood test, and also the PET scan if there is PET scan is done in selected cases, like if we can guess that there is a germ cell tumor and we think that there is inadequate surgical staging, or we want to restage after giving the patient chemotherapy, we can do the PET scan. So PET scan will not be done in preoperative period, but after operation, we can go for PET scan. Okay. Okay, so let's start with this germinoma among the germ cell tumors. This is the commonest. As I said, in the strategy, they have mentioned it is 45%, and in the talk, they have said about 30 to 40%. So we can say that it's around 30 to 45%. So they 10 to 20% may be bilateral, and it actually arises from undifferentiated formal germ cells and associated with this genetic gonad. We all know, like in androgen insensitivity syndrome, if the patient comes with gonadal dysgenesis, we always advise about the gonadectomy. So why do we actually advise about gonadectomy? As because there is differentiated cells in the gonad of a gonadal dysgenesis patient, so it can turn into a cancer that is the dysgerminoma. That's why actually we advise for gonadectomy. So it may be associated with this genetic gonad. So majority, like 75% of the tumors occur before the age of 30 years. So they can give a scenario like 20 years old girl came to you and with the complaints of amenorrhea, and she does not have any other complaint, like she has nice feature, a feminine feature like the structure of the breast is okay, sparse pubic hair is there. So we can guess that androgen insensitivity is there. But they may ask the question that she has gonadal dysgenesis and what type of cancer is she in risk? So we can answer that dysgerminoma. So it may coexist with pregnancy if the patient does not have any gonadal dysgenesis, and it may be associated with choriocarcinoma or endodermal sinus tumor. So the pathology shows that dysgerminoma microscopically exhibits nest of polygonal cells with prominent nucleoli and clear glycogen-filled cytoplasm. And there may be also intense lymphocyte. Okay, so now come to the treatment of dysgerminoma, and this is the table I have taken from the talk. You just have to go through these tables, and they have actually written very nicely in the table regarding the treatment of all type of cancer. So in case of dysgerminoma, they actually stages all the cancers like we have studied in the FIGO classification of the ovarian cancer. So each of the ovarian tumor can be staged in such a manner, that is 1A, 1B, 1C, 2A, 2B, 3 and 4. So in 1A, fertility sparing surgery or full surgical staging with active surveillance. And what is active surveillance? We will come in short. And 1B to 1C, the fertility sparing surgery can be done or full surgical staging. If fully staged, we have to do the active surveillance. 2A to 4, we can go for full staging debulking surgery with adjuvant chemotherapy. And for 3 to 4 specifically, we have to go for the full staging surgery with adjuvant chemotherapy. So one thing I have to mention that these germinoma are very sensitive to radiation as well as chemotherapy. So why we are choosing chemotherapy? This is because the dysgerminoma can occur in very early age, below 30 years of age. So that's why there is a chance of loss of fertility is a problem when the radiation therapy is given. That's why we actually avoid the radiation therapy and we go for chemotherapy. Okay, so before moving the next slide, as because this is taking time, can you guys write in the chat box that have you understand about dysgerminoma? Do you have any question regarding dysgerminoma? Okay, so now come for the immature teratoma or malignant teratoma, and all of you know that the mature teratoma is the benign one, so they have discussed about the immature teratoma only, and this is derived from the 3 germ layers of the embryo, and this is the second common germ cell malignancies. Can you write down in the chat box which is the first common germ cell malignancy, please? Quickly. Hello, everyone. Anyone writing? It is the first common type of germ cell tumor. Am I audible to all of you? Hello. Yes, exactly. Thank you, Dr. Nishat. Okay, so the pathology of the immature teratoma, we can see that it actually depends upon what type of from what type of cell that the teratoma has arisen, and it actually depends upon whether if the development of the tissue that is going on the along the normal line, it results in immature teratoma, that is benign tumor. But if there is abnormal maturation of these elements, we can say this is the immature teratoma. Okay, so what is the treatment of immature teratoma? They have classified into grade 1, grade 2, and 3 in 1A staging. So the fertility sparing surgery or full surgical staging with active surveillance, and in grade 2 to 3, the fertility sparing surgery or full surgical staging should be done with active surveillance if there is no postoperative tumor markers. And if there is any positive postoperative tumor markers, the adjuvant chemotherapy should be given. And in case of 1B and 1C, the fertility sparing surgery or full surgical staging and adjuvant chemotherapy should be given. And from stage 2A to 4, full staging or demarking surgery with adjuvant chemotherapy should be done. And further cytoreductive surgery for residual disease may be appropriate. So this is two of the tumors. So regarding the treatment of the immature teratoma, the surgery in a premenopausal patient whose lesion appears to be confined to a single ovary, unilateral oophorectomy and surgical staging should be performed. But for a postmenopausal patient, we can go for total abdominal hysterectomy and bilateral salpingo-oophorectomy. And one thing I have to mention that contralateral involvement is rare. That's why we should not take any routine resection or wedge biopsy of the contralateral ovary in case of a premenopausal woman who are yet to be complete her family. Okay, next comes the endodermal sinus tumor. It arises from the primitive yolk sac, and 15 to 20 years of age is a common and third most common malignant germ cell tumor, and they are unilateral for 100% cases. So the association of such lesions with gonadal dysgenesis must be appreciated, and chromosomal analysis should be performed preoperatively in premenarchal patients. As I already said in this germinoma, that this germinoma also can be associated with endodermal sinus tumor. So the same goes for the endodermal sinus tumor also. So from the very beginning of our medical life, we are very familiar to this term, the Schiller dual body. So this is the feature of endodermal sinus tumor, and often RCT gives questions related to endodermal sinus tumor, and they actually does not mention the term Sheila dual body. They actually explains that a woman of 20 years came to you and she was having an ovarian tumor, and you decided to go for an operation, and after operation you have sent the specimen for histopathology, and the pathology shows that the presence of cystic space lined by flat epithelium within this space, a tuft of vascular tissue is often seen. So what is the diagnosis? So you have to be sure about the finding of the Schiller dual body, and this is a very common question in the EMQ. Okay, and these are very highly malignant, and it spreads to the adjacent structures rapidly, and it's easily solid, and the gut section shows the gelatinous or hemorrhagic area. Okay, so the treatment shows that it consists maybe a surgical exploration, unilateral salpingo-oophorectomy, and a frozen section for diagnosis. The addition of a hysterectomy and contralateral salpingo-oophorectomy does not alter the outcome, as I already mentioned, and the association of such lesions with gonadal dysgenesis must be appreciated, and chromosomal analysis should be performed preoperatively in premenarchal patients. And in case of advanced disease, we have to go for chemotherapy followed by the surgery. So what is the what is the treatment for yolk sac tumor, that is the endodermal sinus tumor. From 1A to 1B, the fertility sparing surgery or full surgical staging should be done. And as I mentioned earlier, if fully staged and negative postoperative tumor markers, we should go for active surveillance. But if it is not fully staged and or there is some positive postoperative tumor markers, we have to go for adjuvant chemotherapy. And from 1C to 4, full staging with debulking surgery with adjuvant chemotherapy should be given, as because these are highly malignant tumors. Okay, so this is the overall management of the malignant germ cell tumors. In summary, from the talk, that the malignant germ cell tumors account for 1.5% of ovarian cancers and 60 to 70% are diagnosed in the early stage. So this is fortunate because in early stage, we can increase the rate of 5-year survival rate. Okay, so usually treated with surgery followed by active surveillance or adjuvant chemotherapy. And the malignant tumors are most sensitive to chemotherapy, as most patients presenting with the malignant ovarian germ cell tumors are adolescents or young women. We have to focus the management as chemotherapy alongside the fertility conserving surgery. And the full surgical staging is the gold standard, and in case of young patient, the fertility sparing surgery should be the first choice. And if the family complete, we can go for the medical surgery, and there is no need for lymphadenectomy. And these are some points from the talk, and they have said that the woman should be counseled to avoid pregnancy for first 2 years. We all know that in case of the patient who are taking the chemotherapy, we usually advise to avoid pregnancy for 2 years. So this comes here also, that we have to avoid pregnancy for first 2 years. Okay, and we have to commonly used regimen in case of chemotherapy are BEP or the BOMB-ACE. And what is BEP? This is the bleomycin, etoposide, and cisplatin. And BOMB-ACE is the cisplatin, vincristine, methotrexate, bleomycin, actinomycin, cyclophosphamide, and etoposide. So I am not scaring you all to remember all the drugs name, but try to take a glance at the name of the drugs so that if there is any question, you will not miss. Okay. So the surgical treatment summary is the fertility preserving surgery via the midline incision. The midline incision is preferable and the laparoscopy is not preferable, as because there is chance of spillage, and which we definitely want to avoid, and it is accepted standard of care in early stage disease. Biopsy of a contralateral normal ovary is not recommended. They have mentioned it several times that the contralateral normal ovary should not be taken, the biopsy. Okay, and in advanced stage, the chemotherapy is recommended as primary treatment, followed by completion surgery, resect the residual masses. So in case of advanced stages, we have to give the chemotherapy first, and then we can go for the surgery. So in case of recurrence, what we have to do, the surgical removal is recommended again and followed by chemotherapy if there is any adverse feature. And full staging is achieved through a surgical approach, and it includes, what is the full staging? Omentectomy, biopsy of the peritoneum, and pelvic para-aortic lymph nodes along with pelvic washing. Now, what is the adjuvant chemotherapy? I also already have mentioned about the name of the drugs, that there are some short and long-term complications related to the PEP chemotherapy. These are the ototoxicity, nephrotoxicity, pulmonary dysfunction, Bennett's phenomenon, secondary malignancies like acute myeloid leukemia can occur. So there is also risk of gonadal dysfunction leading to iatrogenic menopause and sterility. Therefore, women have the option of oocyte prior preservation. There is another percentage you must have to remember from this talk, that is the premature ovarian failure after chemotherapy, which is 3%. The premature ovarian failure after chemotherapy is 3%. Okay, so what is the follow-up after chemotherapy? Approximately 75% of the tumor recurrence occur within the first year. So intensive early follow-up every 4 to 8 weeks appears to be appropriate. Okay, and the common site of recurrence are the peritoneal cavity, and also it can occur in the retroperitoneal lymph nodes and lungs. So as I was mentioning in each of the treatment chart, active surveillance, and active surveillance. What is this active surveillance? In case of patients where we are not sure about the staging, and also we are not, we have found any positive finding of the tumor markers, we have to go for active surveillance. So this active surveillance is, we have to examine the patient, we have to do the pelvic ultrasound, we have to do the tumor markers, chest X-ray, and CTAP. Okay, so up to 5 years, we have to remember how we are going to examine the patient, when we are going to do the ultrasound scan, when we are going to do the tumor markers and chest X-ray as well. So in the first year, we have to examine the patient monthly, and in the second year 2 monthly, third year 3 monthly, fourth year 4 monthly, and 5 year to 5th year to 10th year we have to go for 6 monthly. So remember this time period, and remember that the examination should be monthly, 2 monthly, 3 monthly, 4 monthly, and 6 monthly. And the pelvic ultrasound goes with the table of 2, like 2 monthly, 4 monthly, 6 monthly, and also the tumor markers every 2 weeks, then 2, 3, 4, 6. In the chest X-ray, 2 monthly, 4 monthly, 6 monthly, 8 monthly. Again, this is the table of 2. And after the 5 years of the malignant ovarian germ cell tumor removal, we have to do the chest X-ray annually. Okay, so this is a scary chart, I know, but if you can be tricky, you can recall the chart. Okay, so this one also given in this talk, it's showing that what is the when we can call the dysgerminoma good, when it is intermediate, and when the outcome is poor. So in this chart, you have to specifically remember the tumor markers, as because there may be sometimes a question came from in the SBA that they mentioned that the alpha fetoprotein finding was less than 1,000 and HCG is less than 5,000. So what do you think the tumor according to the stratified risk model? So you can say this is the good type of dysgerminoma or good type of malignant ovarian germ cell tumor. Okay. So any question from malignant ovarian germ cell tumor? I can see Dr. Chavi, Dr. Shawi, Shashi, Taslima, and Dr. Nishat. Any one of you, do you have any question related to germ cell tumor? What I have mentioned all is from the talk, and you guys know a lot from germ cell tumor, as because there is a separate chapter in the strategy, the germ cell tumors, and as because this is the newest talk, so they may choose it for any type of question. Now come the sex cord-stromal tumors. So according to the WHO 2014 classification, the sex cord-stromal tumors are pure sex cord tumors, and the sex cord tumor, pure stromal tumors, and also the mixed sex cord stromal tumors. So in these 3 types, there are various classifications. Purely, you have to remember that granulosa cell tumor, Sartori cell tumor, fibroma, thecoma, Leydig cell tumor, and the mixed one is the Sartori Leydig cell tumor. Okay, so this is again the tumor markers. You have to remember that in case of thecoma, the raised tumor marker is inhibin. In case of granulosa cell, inhibin, AMH, testosterone. Sartori Leydig cell tumor, alpha fetoprotein, inhibin, testosterone, dihydroepiandrosterone, androstenedione. I want to mention that in case of sex cord stromal tumors, there are a rise of testosterone and androgen. That's why the patient presents accordingly with the masculine features. So first of all, come to the granular stromal cell tumors. The granular cell tumor is this a low-grade malignancy tumor, and rarely the thecoma and fibromas have the morphologic feature of malignancy. And hyperestrogenic state is also there, as because the granules and theca cells secrete the estrogen, and when there is rise of the granules and theca cells, they may give rise of the hyperestrogenic state. And it may present like precocious puberty and abnormal uterine bleeding or endometrial hyperplasia as well. Okay, so these are usually a stage 1 diagnosis. That is, in the early stage, we can diagnose granular cell tumor, but it may recur after 5 to 30 years even. So the tumors may also spread hematogenously, and the metastasis can develop in the lungs, liver, brain, and years after initial diagnosis. So when granular cell tumors do recur, they can progress quite rapidly. So malignant thecomas are extremely rare, and elevated serum inhibin level in a premenopausal woman presenting with the amenorrhea and infertility is suggestive of a granular cell tumor. So the pathology shows another term that we are very familiar, that is the Colexner bodies. And as I said that there may be a case scenario with the feature of Colexner body, and you have to be very sure about Colexner bodies that the feature is sorry, clusters or rosettes around the central cavity. So there is a resemblance to primordial follicles. So if they say that the histopathology is showing primordial clusters of primordial follicles showing like primordial follicles, we can think that this is the Colexner body, and the diagnosis will be granular cell tumor. So in children and adolescents, these are often cystic, contain the luteinized cells, and can be associated with precocious puberty. So how we can diagnose the granular cell tumors which secrete estrogen are seen in women of all ages. They are found in prepubertal girls in 5% cases, and they can be bilateral only in 2% cases. So how we are going to manage the cord-stromal tumors? Okay, so according to the staging, 1A, fertility sparing surgery or full surgical staging with the standard follow-up. And stage 1C1, full staging, debulking surgery, including the TH and BSO. And from 1C2 to 3, full staging debulking surgery, to 4, full staging debulking surgery. So surgery, it is we have to do an unilateral salpingo-oophorectomy, as it is appropriate therapy for stage 1A tumor in children and in women of reproductive age. And in granular cell tumors, the endometrial curettage should be performed owing to the risk of endometrial abnormalities from the hyperestrogenic effects of granular cell tumors. Next comes the Sartori Lily cell tumor, and this is the hyperandrogenic testicular cell type, and they may be present with defeminization, that is loss of hip fat and breast atrophy. There may be hirsutism, there may be irregular menstruation, hoarse voice, and may pattern baldness. And the pathology is another term, rinky crystals, which are the best demonstrated by in the pathology, that is histopathology, and it can be found as the in the hyalus cell like vacuolated or granular eosinophilic cytoplasm. These tumors are typically produce androgens, and clinically there is the virilization about 70 to 85% cases. So the signs of virilization, as I already mentioned, there are a few more like oligomenorrhea, maybe breast atrophy, and acne, hirsutism, clitoromegaly, deepening of the voice, and a receding hairline, that is the baldness. And measurement of plasma androgens may reveal elevated testosterone and androstenedione. Okay, so this is the treatment, and this is very easy because they have stage given the stage 1A and more than 1A. If it is stage 1A in young patient, fertility sparing surgery or full surgical staging should be done. In older patient, full staging surgery including TH with BSO. If the tumor is poorly differentiated, we have to go for adjuvant chemotherapy after surgery. And in more than 1A, full staging debulking surgery, including TH with BSO and adjuvant chemotherapy should be given. Now, the overall management of sex cord-stromal tumors. 60 to 95% are diagnosed in the early age, and treatment is surgery with adjuvant chemotherapy. These are less chemosensitive. It is not chemosensitive as the germ cell tumors we have read earlier. That means full staging surgery, including hysterectomy and bilateral salpingo-oophorectomy, is recommended. But in case of malignant ovarian germ cell tumor, we can go for the fertility sparing surgery in the early stages. But in case of sex cord-stromal tumors, we have to go for the full staging surgery. And it can be done in young patients, the fertility sparing surgery, and the chemotherapy, 3 to 4 cycle of the BEP or EP. So what is the active surveillance in case of sex cord-stromal tumor? We have to take the history, examination of tumor markers from the 3rd year and continue indefinitely 6 monthly, and plus 6 monthly pelvic ultrasound for women treated with fertility sparing surgery. So this is the surveillance how we have to do in sex cord-stromal tumor. Now, the last type of tumor of this dog, that is the small cell carcinoma of the ovary, and also they have ovarian sarcoma. These are not that common. That's why you are, this is enough to read these 2 slides. You don't need to go through the whole the paragraph in the talk. That the small cell carcinoma of the ovaries are aggressive ovarian tumors, and these are characterized by malignant rhabdoid tumors. And it may present at presentation maybe on the 24 years, and the serum calcium levels are elevated in approximately 2/3 of the patient. So hypercalcemia, there may be one of the presentation, and most tumors are unilateral, and 50% of the tumor demonstrate that extra ovarian spread are there. That is in the advanced stage. They are chemosensitive, and but there is a high risk of relapse. So we have to do the complete surgical staging followed by adjuvant chemotherapy, or even pelvic radiation can be given. Okay, the 5-year survival rate is only 10%. That is, actually, the death rate is very high, as because this tumor is very aggressive. Now comes the ovarian sarcoma, the adenosarcoma, the carcinosarcoma. These are the ovarian sarcomas, and angiosarcoma, leiomyosarcoma, liposarcoma. There are a few more varieties, and usually it presents in 80% of postmenopausal women. That is, the previous tumors were presented in the early ages, but ovarian sarcoma can present in postmenopausal women as well. These are also aggressive tumor. So we have to do the aggressive surgery, and after surgery we have to go for chemotherapy, along with the cisplatin, doxorubicin, ifosfamide. And the prognosis is poor, and long-term survival is uncommon. So these are the 2 uncommon tumors of ovary, non-epithelial ovarian origin. And now come about the hormone replacement. There is a paragraph in the talk at the last, that hormone replacement therapy. There are no robust data to evaluate the safety of HRT for the non-epithelial ovarian cancers. However, the hormone-dependent nature of sex cord-stromal tumors, that's why HRT is not recommended and should be avoided in these patients. So as I have said that in sex cord-stromal tumors, the granulosa thicker cell tumors releasing estrogen, and also the sartorilytic cell tumors are secreting androgens. That's why we will not prescribe HRT in these patients. But in case of malignant ovarian germ cell tumors, HRT is usually considered to be safe, and hormonal contraceptives are not contraindicated. Okay. So this is the FIGO classification of tumor. We all know about that. And this is a 5-year survival rate of ovarian cancer. Now it depends upon whether it is localized, it's regional, or it is distant. You have gone through the if you go to the EMQs, in recent years, they have given a question related to 1-year survival rate. And that question actually came from the Cancer Research UK website. And if you go through the Cancer Research UK, you can see the 1-year survival rate. I'm pretty much sure that all of you have the note of 5-year survival rate from the strategy. And I will request you to go through the 1-year survival rate as well, as because in my exam, they also gave this question. Okay. So any question from this topic? Anyone? Hello? I will be requesting all of you can unmute your microphone, and if you have any question, you can ask me. So if you don't have any question, I'm going to ask you 5 questions, which are from the RCOG website. Any one of you have given the exam, part 2 exam yet? You can raise your hand button. Or planning to do the exam on 5th July? Hello? I'm asking whether you are going to appear in the exam on 5th July? Any one of you? Okay, so here is the 5 questions from the RCG website related to this talk. I would request you all to write down the answer in the chat box so that I can think that you have understand the topic, okay? So, number 1, a 39-year-old woman has a 5-month history of vague lower abdominal pain, anorexia, and weight loss. The pelvic examination reveals a possible mass in the right adnexa. What is the most appropriate investigation to request to diagnose the ovarian malignancy? The CT scan of the pelvis, the MRI of pelvis, serum CA-125, serum lactate dehydrogenase, transvaginal ultrasound. So Dr. Shashi has given the answer serum CA-125. Okay, rest of you, please answer the question. It will just clear your idea about the SBA, okay? So please give an attempt to answer the question. It will be very helpful for all of you. Okay, so the answer is we have to go for TBS first, as because the patient is not postmenopausal, she is premenopausal, and we have to go for TBS. Is that clear, Dr. Shashi? If you have any question, please write down in the chat box. Okay, so the next question is a 42-year-old woman is diagnosed with a non-epithelial cancer of her left ovary. As part of her preoperative workup, she has endometrial sampling performed. And for what type of tumor is this investigation necessary? Can anyone mark it? Okay. Okay, so the answer is granulosa cell tumor. Very good, Dr. Shashi. As because this releases estrogen, it may cause endometrial changes, and there we should be doing the endometrial sampling beforehand the operation, and it may give rise to endometrial carcinoma as well. So the third question: 24 years old woman has gone for fertility sparing surgery for germ cell tumor. She wants to plan for pregnancy. How long she should wait? I would be expecting from all of you answer. Should it be 6 months? She's receiving chemotherapy. Should she wait for 6 months, 12 months, 18 months, 24 months, or 60 months? That is a half year, 1 year, 1.5 years, 2 years, and 5 years. If a patient is having chemotherapy, how long she should wait for pregnancy? I just have mentioned it during the slides. Anyone can answer. Okay. Okay, so the correct answer is 24 months. As because I have said after chemotherapy, we have to wait for 2 years at least. Okay. Okay, now comes the fourth tumor. The tumor markers to be repeated during the first year of surveillance after the malignant ovarian germ cell tumor in first year. We have seen this in the scary chart, so I hope everyone can answer. Every 2 weeks, every 4 weeks, every 6 weeks, every 2 weeks for 6 months, and every 4 weeks for rest of 6 months, every 2 weeks, 8 months, then monthly for rest 6 months. Sorry, the question disappeared. Okay. Okay, thank you, Dr. Nishat, for the previous answer, and Dr. Shoshi also. Now answer this quickly, please. I'm pretty much sure you guys can do it. Every 2 weeks every 2 weeks, every 4 weeks, every 6 weeks, every 2 weeks for 6 months, then every 4 weeks for 6 months, every 2 weeks for 8 months, then monthly for rest of the 6 months. Okay, so I think this is a bit hard. So the answer is every 2 weeks for 6 months and every 4 weeks for rest 6 months. Thank you, Dr. Nisha, for the attempt. But if you go through the chart, you will be more clear. Okay. And the last question. A 17-year-old girl without a significant past medical history has been diagnosed and treated for a yolk sac tumor. Which tumor marker should be most appropriate to use for follow-up? So this is the question. Okay, let's see the answer, what everyone is answering. Okay. Yeah, so for the yolk sac tumor, the tumor marker is alpha fetoprotein. So we have to remember all of the tumor markers related to the ovarian cancer. So this was the last question from this slide and this talk, and I would request all of you to go through the germ cell tumor part of the strategy. There are so many questions, and also in the RCG website they have questions related to the talk. If you guys can't find, please notify me in the group. I will help you to find it out, and because from that source they usually give 2 to 3 questions every session, so you have to be very clear about that questions, and you must have to solve the questions. Am I clear so far, everyone? Okay, so anyone can open up the mic, and if anyone have any question, please ask me. I'm here to answer you. And if there is any problem related, I'm extremely sorry because of the delay in the slideshow, and I hope in the next class it will be solved. And if you find any problem, please knock me. I will be there for you. Okay.
Okay, ma'am.
Okay, thank you so much. Take care, everyone. So this is the talk class, and I hope you have find it useful for you. Thank you.
Thank you, ma'am.